The fourth condition of sphingolipidosis, this includes the Fabry disease. Fabry is another X-linked recessive condition where we have deficiency of one lysosomal enzyme called galactosidase enzyme, alpha galactosidase. So there is a storage of sphingolipids or glycolipids, especially in lysosomes of vascular endothelium. And so blood vessel walls are the most affected by this condition. Heart, kidney, and spinal ganglia or nervous system also the main affected organs. Again, we have X-linked condition. The mutated gene that include 4 alpha galactosidase enzyme lie on the X chromosome, so present mainly in males, but sometimes females can show milder condition due to the random inactivation of X chromosome, as we have mentioned before. So mutation of this gene will result in accumulation of class of lipids called glycolipids inside the lysosomes of different organs. These include blood vessel walls, include the heart, kidneys, and the brain. Presentation usually in a boy, maybe an adolescent boy presenting with attacks of severe burning pain in his extremities, or what's called the acroparesthesia. It is a burning pain related to the neuropathy with attacks of hypohidrosis. There is deficient sweating, and subsequently there is febrile episodes. So we have episodes of fever that is related to the hypohidrosis or deficient sweating, and the severe burning pain, which is agonizing pain, occur in the extremities of this male. So this number one in the presentation. The other presentations include the Angio Keratoma. This is a skin lesion called Angio Keratoma in this area of the trunk. It's called the bathing trunk area. This is characteristic for Fabry disease, and we have a skin lesion called angiokeratoma, and we have burning pain, but it would not be lethal. But the most important long-term complications are related to renal failure, cerebrovascular disease due to the affection of vascular endothelium. So attacks of stroke and cerebrovascular accident can occur, and the cardiomyopathy due to the lysosomal storage. These are the most serious long-term complications of Fabry disease. So the presentation is in a boy having angiokeratoma, skin lesion in the bathing trunk area, and severe burning pain in his hands and feet with febrile episodes. Okay, but the cause of this will be the renal failure, the cerebrovascular disease due to endothelial affection, and the cardiomyopathy. Usually they have normal intelligence, and the good news that we have enzyme replacement therapy using the recombinant technology for production of the alpha galactosidase enzyme. So this is a summary for the Fabry. We have febrile episodes, this for F, and A for angiokeratoma, and the name of the enzyme alpha galactosidase A deficiency, and the presentation B for burning pain due to peripheral neuropathy of hands and feet, and the R for renal failure, and the Y for death, and this is related to the renal failure and the cardiomyopathy and the cerebrovascular disease. C for the ceramide. This is a class of lipids that is stored in the lysosomes, and the cardiovascular disease related to the endothelial inflammation and also to the storage in the myocardium. So these were the sphingolipidosis. We have discussed the Tay-Sachs disease or GM2 gangliosidosis. Sandhoff was a variant, okay, and then we discussed the Gaucher disease, Niemann-Pick disease, and finally Fabry disease. Bombay disease, the type 2 glycogen storage, also considered one of these inborn errors. Now discussing one rare disease, that is porphyria. Porphyria is a disorder of heme biosynthesis. It is one of the few conditions that has autosomal dominant pattern of inheritance. These include the familial hypercholesterolemia and porphyria. Both have autosomal dominant pattern of inheritance. This is the deficient enzyme, aminolevulinic acid synthase. This is involved in the production of hemoglobin. Okay, so if you remember that heme has hemoglobin, we have globin part that is amino acids, and the heme part, and the heme part that carries the iron atom, okay, plus the protoporphyrin. One of enzymes involved in the metabolism of heme is deficient here, resulting in build-up of porphyrins in the body, and this will result in negative effects on the skin or nervous system. So we have types of porphyria. The first type is acute, can present acutely with severe and lethal presentation. This is neurovisceral presentation. But the other presentation can be just cutaneous manifestations without any neurological manifestations. Okay, so we have cutaneous forms of porphyria. The patients have blisters, have scarring, pigmentations, fragility, and hirsutism. Okay, so just cutaneous presentation. Usually they follow in the clinic of dermatology. Sometimes the presentation of porphyria by photosensitivity. Sometimes both skin and neurovisceral manifestations present in the same individuals. So we have different presentations for porphyria, either acute neurovisceral presentation or chronic cutaneous only, okay, or cutaneous plus neurovisceral presentation. For all, the diagnosis will be detection of porphyrins, okay, which appear in urine, in feces, and in blood. We can do blood testing for the porphyrin, screening usually by the urine porphyrin. Build-up of porphyrins that appear in urine gives the urine its characteristic red color, and sometimes due to rarity of the condition, and the condition usually missed due to its rarity, sometimes it is diagnosed by appearance of when the urine is left okay, in the toilet or in a cup like this, it will turn into a red color due to accumulation of porphyrins. So talking about acute attacks of porphyria that usually present in girls after puberty, where we have attacks provoked by some factors like stress, and this include the menses, okay, or menstrual periods in females. Other provoking agents may be infection, surgery, and others. So the presentation is called neurovisceral. So we have severe abdominal pain and other pains in the back or in the leg. So we have severe back pain, severe leg pain, or severe abdominal pain as the presentation, with neurological manifestations in the form of pain in different areas, weakness, even paralysis, okay, fits can occur, and finally mental changes and up to coma. So one child or girl presenting to the ER with severe abdominal pain, complaining of back pain or leg pain, with a progressive course, okay, up to paralysis and seizures and up to coma. Usually the diagnosis is delayed. GIT manifestation includes the abdominal pain, vomiting, constipation or diarrhea. Cardiovascular manifestation in the form of tachycardia and hypertension occur in this neurovisceral presentation. So usually finding the red color would raise suspicion of the diagnosis of porphyria. Having another case in the family, as it has autosomal dominant pattern of inheritance, may raise the suspicion. Screening in a fresh urine sample by the urinary porphyrin or porphobilinogen would be the diagnostic test. Treatment of this acute attack will be by carbohydrate infusion, shut down the heme synthesis, okay, and so stop the build-up of porphyrins, reducing their level in the blood. Okay, plus the new medication of heme arginate. Heme arginate given is IV infusion. Also, it suppresses this enzyme and reduce the build-up of porphyrins. So this was porphyria. Now more rarer errors to have a small idea about each. Smith-Lemli-Opitz syndrome. It is frequently asked in the exam. Smith-Lemli-Opitz syndrome, it is biosynthetic defect in cholesterol. Okay, and if you remember, cholesterol was the first substrate of all hormones of the adrenal gland. For example, cholesterol is very, very important in lipid synthesis all over the body, enter in synthesis of different organs. So when we have a biosynthetic defect in cholesterol, so the course will be dramatic. We have major organ dysplasia, skin and limb abnormalities, dysmorphic facies. Okay. If you remember, we have microcephaly, we have upturned nose, okay, we have ptosis. So we have dysmorphic features in those patients. We have genital anomalies, usually hypogonadism related to the defective adrenal hormones, and learning disability. Logically, we will have brain dysplasia due to this cholesterol biosynthetic defect, renal anomalies. Logically, we have filtering growth, and cholesterol level will be low due to this biosynthetic defect with accumulation of its precursor, which is 7-dehydrocholesterol. Treatment for this supportive, there is no specific treatment. This autosomal recessive condition that has a dramatic course, and this usually occur early in life. Lesch-Nyhan syndrome. Lesch-Nyhan syndrome, another X-linked condition. So X-linked conditions, remember now the X-linked adrenoleukodystrophy, remember the Fibroid disease, remember the Hunter syndrome, remember the OTC and the urea cycle defect, okay, OTC deficiency. Also remember Menkes disease, this disorder in covered transport, and also Lesch-Nyhan syndrome. All these are X-linked recessive condition. Now this disorder of purine metabolism. If you remember, DNA has purine and pyrimidine units, and imagine if you have disorder in purine metabolism, so also the course will be dramatic. Okay, so presentation is varies, affecting different organs, but we have characteristic features. We have motor presentation in the form of dystonia, acetosis, and spasticity. Finally, spasticity will occur with pulpar speech and feeding difficulties. Okay, those are patients with Lesch-Nyhan syndrome. They have choreoacetosis and dystonia. Okay, plus the spasticity, and usually they are paralyzed and bedridden. They have filtering growth. We have disorder in urine metabolism. Okay, you can imagine. So uric acid is the end product of urine metabolism. So we have hyperuricemia. Hyperuricemia, elevation of the level of uric acid. This will be associated by renal stones that are radiolucent stones, and okay, if we have done plain X-ray, and may end by nephropathy, obstructive uropathy, and gout due to the hyperuricemia. The very characteristic hallmark of the disease is the compulsive self-mutilating disorder. Those patients mutilate themselves, they injure themselves in an uncontrolled fashion. Okay, so they are obliged to injure or mutilate themselves. Okay, so they bite their lips like this, bite their fingers like this, and so usually they are restrained, okay, to prevent them from injuring themselves. Okay, so we need to use special chairs with restraints. Also, they would be restrained in beds, okay, and use these appliances to prevent them from biting their tongues and their lips, okay, to prevent themselves from mutilating themselves. This is compulsive. Okay, and this is a hallmark of this disease. They have cognitive impairment, subnormal IQ. The diagnostic, the history, usually he is a boy, and he may have another sibling with the same condition, and this usually occur early in life. By doing screening for the level of uric acid, okay, it is done in urine or blood, okay, but because children clear uric acid very effectively, so it is preferred to measure the uric acid in urine. Enzymology would confirm the condition, and the treatment will be by allopurinol to reduce the level of uric acid, plus plenty fluids also to prevent the risk of obstructive uropathy. So it is supportive treatment, but no specific treatment for Lesch-Nyhan syndrome, and finally this usually occurs. Okay. Menkes syndrome, it is another X-linked condition associated with membrane cover transporter defect. Membrane cover transporter defect, it is a very rare condition. So those patients, usually a male, who ingest the cover in the diet. Okay, cover will be absorbed normally to the blood, and we have cover content normal or high in the blood, but transporter of cover is mutated. Okay, so it will not reach this organ. These organs will not get benefit from the cover present in plasma. So brain will have low cover, skin and the hair will have low cover, bones will have low cover. Okay, but high cover content in the blood will be cleared in by the kidney. Okay, so cover requiring enzymes do not receive the necessary cover for normal function, and many enzymes have cover in their structure. So presentation also will be dramatic, and early death will occur if the diagnosis is missed. Okay, so presentation in the form of hypotonia, epilepsy, hypothermia. We have neurological manifestations plus characteristic spores, kinky hair. Usually those males have this characteristic kinky spores hair. This is another infant showing the spores and the kinky and light colored hair related to copper deficiency. Okay, plus neurological manifestations, the form of hypotonia and epilepsy, plus retardation. Brain cannot get sufficient amount of copper, so we have a delay in acquisition of milestones, and we have psychomotor retardation. Okay, early this will occur maybe in the infancy if the diagnosis is missed. If someone suspects the diagnosis of Menkes disease, so serum level of copper will be found to be low, and the ceruloplasmin. This is the opposite of Wilson disease that will be discussed in the chapter of hepatology, where we have also low levels of ceruloplasmin, but we have high levels of copper. Okay, but here we have low serum levels of copper and ceruloplasmin due to the transporter defect. The treatment will be by replacement of copper by daily copper histidine injections. Okay, but this requires early treatment. If the treatment started early in life, during the first few months of life, this can improve the outcome of this condition. Okay, so presentation by infantile hypotonia like this have many differential diagnoses, and inborn error of metabolism should be in the top besides the congenital benign hypotonia, benign having Down syndrome or other trisomy. Okay, we should consider inborn error of metabolism as a cause for the infantile hypotonia. And this is a poor child who has this characteristic hair and the poor general condition due to deficiency of copper.